Hello friends, today we are going to discuss about acute pancreatitis. It is the inflammatory condition of pancreas, this red colored organ which we can see in the diagram. It is our pancreas. So let's see something about this pancreas first. So we will discuss in short the anatomy of pancreas. So many scientists found this pancreas very interesting. So Rufus Ephesus, who named pancreas organ pancreas, which means in Greek pan means all, creas means flesh or meat. Homer used word sweet bread to describe pancreas as a animal flesh, as it looks like that, and Monian described pancreas as an abdominal tiger. So let's discuss about this abdominal tiger. Pancreas. So pancreas is a gland located deep in the abdomen, retroperitoneal area. It lies between stomach and spine, second and third lumbar vertebra. It extends on the right side from duodenum towards the spleen on the left side. It has four parts: head, neck, body and tail. Head lies in the C-loop curve of the duodenum. So let's see the diagram of the pancreas. So this is our beautiful pancreas. On the right side it has C-shaped loop of duodenum. On the left side it will have the spleen, and it has four parts: head, neck, body and tail. And here we can see the green colored structure, that is bile duct, and this is the duct of Wilson, which is the main pancreatic duct. They join to form the papilla of water. This papilla of water contains the muscles, where the muscles name is sphincter of Oddi, which helps in the contraction and relaxation of this common duct. Okay, so now we will see the blood supply of pancreas. So pancreas has arterial blood supply from three main arteries: pancreatic branches of splenic artery, superior pancreaticoduodenal artery and inferior pancreaticoduodenal artery. Its venous drainage is into the portal vein. It has its nerve supply from parasympathetic from vagus and sympathetic from splanchnic nerves. So we will see the diagram of the arterial supply of pancreas as we discussed before. That is, it contains blood supply from three main arteries, that is pancreatic branches of splenic artery, superior pancreaticoduodenal artery, inferior pancreaticoduodenal artery. Venous drainage, it drains its blood into the portal vein. Okay, and then this is the ducts of pancreas. It contains this is the ducts of Wilson, which is the main pancreatic duct. This is the duct of Santorini, which is the minor papilla, and this duct of Wilson and common bile duct. This green colored is common bile duct, which forms the papilla of water or major duodenal papilla, which opens into the duodenum. So what are the functions of pancreas? Pancreas has dual functions as it contains two main components, endocrine as well as exocrine. So endocrine function is concerned with production of hormones, that is insulin, glucagon. As we know very well about it, it regulates the blood sugar level. And exocrine function is concerned with secretion of digestive juice, that is pancreatic juice. So now we will discuss our main topic, that is acute pancreatitis. So what is acute pancreatitis? It is the reversible pancreatic parenchymal injury. It is parenchymal injury associated with inflammation and has diverse etiologies. So these etiologies include toxic exposures, example alcohol, pancreatic duct obstruction like biliary calculi, inherited genetic defects like mutations in the genes, which includes PINK1 gene, which will come further, then vascular injuries and infections. So what actually happening in this pancreatitis? This pancreatitis is initiated by injuries that lead to autodigestion of the pancreas by its own enzymes. So now we will discuss the pathogenesis of pancreatitis. So first of all, we will see how this is taking place. But before that, we should understand what is the normal protective mechanism of pancreas, which protects pancreas from self-digestion. So in the pancreas, it's most of the digestive enzymes which are synthesized in the inactive proenzyme form. So it is synthesized in inactive form, so it will not harm the pancreas itself. Okay, So they are synthesized in inactive proenzyme forms, which are packaged within secretory granules. So these proenzymes then activated by trypsin, but this trypsin is activated by the duodenal peptidases or enterokinase in the small bowel. So this means these proenzymes are also activated into the duodenum. So intrapancreatic activation of proenzymes is normally minimal. So in the pancreas there are acinar and ductal cells which secrete trypsin inhibitors, which further limits intrapancreatic trypsin activity. So this trypsin inhibitor includes serine protease inhibitors Cajal type 1, SPINK1 gene. So what is the normal protective mechanism of pancreas from self-digestion? So most of the digestive enzymes of the pancreas are secreted into the inactive proenzyme form, which are activated by trypsin. But trypsin is activated by duodenal enteropeptidases into the duodenum. So intrapancreatic activation of proenzymes is normally inhibited. Okay, so now what happens in the acute pancreatitis? When acute pancreatitis occurs, there is inappropriate release and activation of pancreatic enzymes. So inappropriate release and activation of pancreatic enzymes destroys the pancreatic tissue and elicits acute inflammatory reaction. This acute inflammatory reaction, which leads to inappropriate intrapancreatic activation of trypsin. As the trypsin is activated, then it will lead to activation of proenzymes such as phospholipases and proelastases, which degrades fat cells and damage elastic fibers of the blood vessels. So intrapancreatic activation of trypsin, which further also converts prekallikrein into the kinin system. With the kinin system, complement system and clotting systems are also activated, which further leads to inflammation and small vessel thrombosis. This inflammation and small vessel thrombosis damages the acinar cells and amplify the intrapancreatic activation of digestive enzymes, which further causes damage of the pancreas. Okay, this is the main pathogenesis of the acute pancreatitis. So this diagram very well explains this mechanism. So this is the duct obstruction. So duct obstruction mainly caused due to cholelithiasis, ampullary obstructions, chronic alcoholism, ductal concretions. This obstruction leads to interstitial edema, impaired blood flow causing ischemia and ischemic injury to the acinar cells. Then acinar cell injury, which is caused due to alcohol, drugs, trauma, ischemia, viruses, hypercalcemia, which causes release of intracellular proenzymes and lysosomal hydrolysis, which causes activation of enzymes, intra or extracellular enzymes. This activation of enzymes further leads to acinar cell injury. Then defective intracellular transport. So metabolic injuries, alcohol, duct obstruction. This leads to delivery of proenzymes to lysosomal compartment and intracellular activation of enzymes, which further leads to acinar cell injury. This acinar cell injury leads to again activated enzymes in the pancreas, which causes interstitial inflammation and edema, plus proteolysis, plus fat necrosis, plus damage to vessel walls and hemorrhage. This all leads to acute pancreatitis. So what are the causes leading to acute pancreatitis? So gallstone induced pancreatitis, this is the most common cause leading to pancreatitis. So what causes pancreatitis in cases of gallstones? So gallstones causes pancreatic duct obstruction. This obstruction leads to increase in intrapancreatic ductal pressure and leads to accumulation of enzyme rich fluid in the interstitium of pancreas. So this in the secretions which are accumulated, although contains many enzymes which are secreted as proenzymes, but lipase is produced in its active form. So lipase has potential to cause local fat necrosis. So it leads to death of adipocytes. Death of adipocytes may be considered as a danger signal as it is leading to pancreatitis. This death of adipocytes, they stimulate periacinar myofibroblasts, leukocytes, to release pro-inflammatory cytokines and other mediators, and which leads to inflammation and pancreatitis. Then alcohol. So alcohol causes transiently increase in contraction of sphincter of Oddi. The sphincter of Oddi is the muscle present at the papilla of water. So due to the contraction there will be accumulation of pancreatic fluid, and this again leads to pancreatitis. And also chronic alcohol ingestion results in secretion of protein rich pancreatic fluid that leads to deposition of inspissated protein plugs and obstruction of small pancreatic ducts, which causes acute pancreatitis. The alcohol is the second most common cause of acute pancreatitis. Trauma, it is the most common cause in children. So trauma, atherogenic post ERCP drugs like thiazide diuretics, ART, chemotherapy drugs, azathioprine, hyperparathyroidism. This all leads to pancreatitis. As drugs, trauma, atherogenic ERCP, this all causes intracellular release of proenzymes and lysosomal hydrolysis, which leads to activation of enzymes and causes acinar cell injury. In the calcium has a key role in regulating trypsin activation. When the calcium level in the blood is low, so it leads to trypsin cleavage, or trypsin tends to cleave and inactivate itself when the calcium levels are low. But when the calcium levels are high, the autoinhibition do not occur, and conversion of trypsinogen to trypsin is favored. As the conversion of trypsinogen to trypsin is favored, it will lead to intrapancreatic activation of proenzymes. So the next cause is increased triglycerides, pancreas divisum, idiopathic cause, and scorpion bite. So now we will see what are the clinical features of pancreatitis. So clinical features includes first of all, it is more common in males and females. So, and then clinical features include epigastric pain which radiates to back and is relieved by bending forward. Patient also has nausea and vomiting, high fever, tachypnea with cyanosis, tenderness, guarding, rigidity, abdominal distension, mild jaundice as in the case of cholestasis due to gallstones, oliguria, acidosis, hypoxia. These are the signs which are seen in the severe pancreatitis, Gray Turner sign, Cullen sign, Fox signs. We will see the pictures of these signs further. Patient also has pleural effusion, pulmonary edema, consolidation, and features of rapid onset of ARDS. Occasionally, they present with hematemesis or melena, which is due to duodenal necrosis, gastric erosion, decreased coagulability, or disseminated intravascular coagulation. So now in this picture we can see the features, clinical features of patient. So patient has fever, jaundice, vomiting, gradual or sudden or severe epigastric pain which is radiating to back and relieved by bending forward, and also has tachypnea. So this is the sign which is seen in the cases of severe pancreatitis. So in the severe pancreatitis, what happens? The enzymes which are intrapancreatic activated. So these enzymes seep across the retroperitoneum, causing hemorrhagic spots and ecchymosis in the flank area. In the flank area, if it occurs in the flank area, it is called as Gray Turner signs. If it occurs in the through falciform ligament causing discoloration around the umbilicus, then it is called as Cullen sign. And if it occurs below the inguinal ligament, it is called as the Fox sign. Okay, now we will see what are the investigations we will perform to diagnose the pancreatitis. So we will see serum amylase. As serum amylase levels are very high in case of pancreatitis, then we will see serum amylase creatinine clearance ratio which is increased. Normal value is 1 to 4%, more than 6% signifies acute pancreatitis. Serum lipase, which is considered more specific than amylase, as pancreas is the only source unlike the amylase, hence the serum lipase is more specific than serum amylase. Then we will perform C-reactive protein test, liver function test, blood glucose levels. Blood glucose levels will show hyperglycemia. Serum calcium levels, hypocalcemia occurs. PCO2 to assess pulmonary insufficiency. Then with that we will perform in plain X-ray, we will see for sentinel loop of dilated proximal bowel, air fluid level in duodenum, renal halo sign, or localized glandular appearance. Then we will perform ultrasound of abdomen. Then spiral CT, which is considered as a gold standard, done after 72 hours. ERCP is usually not done, as we first seen that iatrogenic cause includes the ERCP. So MRI, MRCP should be done in the later date. So these are the investigations. These are the CECT showing pancreatitis with stones in the ducts. This is the CT picture showing features of acute pancreatitis. So what our pancreas is saying, so it is unable to work, please help. So how we will help to pancreas? So it mainly includes conservative treatment. So its name has its treatment. So P for pain relief, pethidine, meperidine, protease inhibitors, and plasma. So A for antibiotics and anticholinergics. So antibiotics includes ceftazidime, cefoperazone, cefotaxime, imipenem, cephalosporins and imipenem. Then anticholinergics are used to reduce the sphincter pressure. N for nasogastric aspiration or nasal O2, nutritional support, total parenteral nutrition, nil per oral. C for calcium gluconate, 10 ml 10% 8 hourly. Cholecystectomy should be done in patients with gallstone pancreatitis before discharge, or calcitonin is given. R for rehydration by IV fluids, plasma, blood, or ranitidine is given IV 50 mg 8 hourly, or respiratory support resuscitation whenever required. Then E for endotracheal intubation, electrolyte management. A for antacids. S for Swan-Ganz catheter for CVP or total parenteral nutrition. Somatostatin and its analogs, that is octreotide, should be given. This is the mainly conservative treatment. So what are the indications for surgical management? So this includes if the condition of patient deteriorates in spite of good conservative treatment, we will go for surgery. Or if there is pancreatic infected necrosis, or in the severe necrotizing pancreatitis, as a trial to save the life of patient, we will perform surgery. So what is the aim of our surgery? Our surgery removes intra and extra pancreatic necrotic tissue, this dead tissue, pancreatic fluid and toxins. So it permits preservation of viable pancreatic tissue. So open surgery is the gold standard for infected pancreatic necrosis. So after open surgery, we will perform laparotomy, necrosectomy, wide debridement, wash, and wide packing. So repeated wash and packings are done until the healthy granulation tissue develops in the open method. So now then we perform Beggar's lavage. This procedure is performed after the initial surgical debridement. So what we do in this procedure, so continuous closed peritoneal lavage of pancreatic bed and laser sac is done with 10 to 12 liters of normal saline or hyperosmolar or potassium free diacylate fluid 2 liters per hour, using multiple tubes to remove toxic materials in the peritoneal cavity, retroperitoneal area, until the fluid becomes clear. A jejunostomy is often done along with this procedure to have early enteral nutrition. Now we will see the image of Beggar's lavage. This is the Beggar's lavage. This is the saline drip. And this is the lavage tube. And this is the pancreatic bed. Okay. So these tubes are placed and continuous saline irrigation through the tube is done until the irrigation fluid becomes clear. So what are the complications of pancreatitis? So shock, hypovolemic or septic. So as the hypovolemia occurs in the pancreatitis due to capillary leak and omitting, which leads to increase in hematocrit, blood urea, and serum creatinine levels, or respiratory failure or ARDS, then septicemia, then hypocalcemia, DIC, acute renal failure, pancreatic pleural effusion, pancreatic pseudoaneurysm, pseudocyst, chronic pancreatitis, and pancreatic ascites. These are the complications. If pancreatitis is not treated, it may lead to these complications. Okay, so now we have given treatment to our pancreas and it is totally cured and relaxing. So you may also relax. Here we ended our lecture. So thank you for listening.